Okay. You know from my previous presentations that we essentially deal with these 4 questions in our medical practice. Either we are behind the diagnosis or treatment of a certain condition, or prognosis or harm. And that's why this EBM course has this structure of diagnostic articles, treatment, prognostic articles, and harm articles. And today is the turn of prognosis. Just to give you a little bit more insight into the prognostic articles, I have an example here. What is the probability of lifetime stroke? Since stroke is a very important mortality reason, actually cardiovascular diseases, not only stroke, but also stroke is very important. You should be aware of the prevalence of this condition. Here. And you should also be aware that it is associated with atrial fibrillation. Atrial fibrillation, approximately 16% of ischemic strokes are associated with atrial fibrillation. What is the prevalence of the lifetime prevalence of the condition? From age 25 onwards, it is in one study, it is given as approximately 25%. It is really high and scaring actually. So the different types of strokes, of course, have different prevalences like ischemic stroke or hemorrhagic stroke, but the prevalence itself is rather high. Therefore, for clinicians, it is very important to classify patients or inform people about their risk profile, about the expected risk concerning this condition, the stroke. And there are calculators, risk calculators developed. One of them, for example, here, this MedIndia tool. Let us click on that. Try to click on that, yeah, hold. And show you the screen. Here is the risk calculator. See, stroke risk calculator, and it takes into consideration several factors like ethnicity, gender, age, blood pressure, diabetes, etc., atrial fibrillation or electrocardiographic changes to calculate a risk. Okay. So there is another one here, this MD called the very often used, often referred T12-2 score, which is to score the atrial fibrillation stroke risk in MD Calc. I will not click on that to save time, but I strongly suggest you also to check the S2 score because it is very frequently used in clinical practice. What I want to say is these calculators, how they develop this, they are of course based on some research on prognosis, and that's our point today, to assess this kind of studies which report us about the prognosis of a certain condition. So patients coming to you will ask questions like this: what's going to happen to my memory if you diagnose them about Alzheimer's disease, for example, or starting Alzheimer's disease? Will I gain function of my arm? What is the probability of regaining my functions after stroke? What is the prognosis in this patient with metastatic lung cancer? what is the risk of stroke in a patient with non-valvular atrial fibrillation? So all these and similar questions will come up in your daily practice. Therefore, you will frequently refer to publications, to research on prognosis. Why do we why do we want to know about the prognosis? Here are some factors. First, it improves the diagnosis. It improves the treatment, your choices of treatment, and it relieves discomfort to know that I have very low risk, for example. Of course, it also can increase the discomfort if you tell the patient that he or she has a very high risk of stroke. But then this is also one reason, one factor to convince the person to change, make life modifications or changes. Or if it is very serious condition, then it may help to prepare for death or disability, avoid unwarranted treatment, and compare outcomes of systems of care. One figure from our wording data, showing you again, is all the introductory slides are to convince you that this topic is important. You see a number of deaths by cause. The leading cause is cardiovascular diseases. Cardiovascular diseases including myocardial infarction and stroke. So prognosis, estimating a prognosis is very important for patients, followed by cancers. So these two make up the most important reasons of death. Therefore, we should be capable as physicians or health professionals to provide some concrete information about the prognosis. Okay. Stroke we have mentioned. Now, what about cardiovascular risk factors? If you take the cardiovascular risk factors, you probably know this list by heart because they are frequently referred reasons of cardiovascular risk. We may categorize them as modifiable and unmodifiable, of course. Sex, for example, is not modifiable. Age also, family history also not modifiable. But many of the cardiovascular risk factors, or in general risk factors, are fortunately modifiable. And using these risk calculators or the scientific available scientific data like these charts, you can foresee and work on the management of the condition with your patients by, of course, the sex is not possible to change, but smoking status can be changed. So when a person changes from smoker to non-smoker, using these risk tables or figures, charts, you easily can convey the message to the patients what is going to be changed. One alternative to these figures or tables, charts, is the risk calculators. And when we speak of cardiovascular risk calculators, we have different guidelines developed for this purpose. One is the ACC-HA guideline, and the Framingham risk calculator is also very famous. You should know. Here, Framingham risk calculator. I must also click on that. That is also very important for me to show you this page and how it works. So as you see in this cvdcalculator.com, this web page, you have different sources for risk calculation. The most famous one is Framingham, but there are also European studies and other mixed studies which provide data from which you can calculate the risks as this web page is doing it. Let us do an exercise. The age of my patient is 55. You see, as you increase the age, because this is a risk factor, you increase your risk, 10 years risk of myocardial or cardiovascular disease. So this is non-modifiable, unfortunately. And if you are male compared to female, you have also an increased risk. This is also not possible to modify. But if your patient is a smoker, and you see that while smoking, he has a total risk of 16.8%. When he quits smoking, the risk will decrease to 9%. This is a substantial decrease, isn't it? So I will not continue with this exercise, but please check this web page and do the exercise actually with yourself, for your relatives, for elderly people, elderly adults in your environment, and practice to see the effect of the power of prognostic evidence in your daily practice, in your daily care. So these are also some other, for example, what happens if you do physical activity, how much benefit it can provide, and so on. But that's, I think, for my purpose enough. Okay, time to make another break.